A quick review: the pharmacology of the anti-diabetic drugs. So we have seen that how an increase in renal glucose reabsorption will be leading to hyperglycemia. Now I'm going to enlarge this area of the proximal convoluted tubules. So here you can see that we have the side of the urine. So we have about like 180 grams of glucose will be filtered per day and will be in the urine. And here we have the blood vessels, about like 160 grams of the glucose which had been filtered. It will be reabsorbed from this area. Now I am going again to enlarge this area here. So you can see it here. We have the lumen where we do have the urine. And here we have the proximal convoluted tubule cells in contact with the lumen with the apical cell membrane. In the apical cell membrane, we have the transporter, the sodium glucose co-transporter type 2, that will be transporting the sodium from the urine to the cells, and at the same time will be co-transporting with the sodium, will be transporting the glucose. Now the glucose which it is inside the cells, now it will be transported to the blood vessels through a specific carrier. It is the glucose transporter type 2. So now if we are going to use a sodium glucose co-transporter 2 inhibitors, that is going now to inhibit the sodium glucose co-transporter 2, and finally will be decreasing the glucose in the blood vessels, and that will be decreasing then the reabsorption of glucose and will be leading to decrease in hyperglycemia. So this group of drugs, which we call it the sodium glucose co-transporter 2 inhibitors, as you can see, all their names is ending with gliflozin. We have Kana, Daba, Imba, Ertu. Now, these medication, all of them, they will be reducing their efficacy if we have a chronic kidney disease. All of them will be leading to some kind of weight loss because they are excreting more sodium followed by more water. And also all of them will be increasing the incidence of genital and urinary tract infections because they are excreting more glucose in the urine. Now, because they are excreting more water, more sodium in the urine, that will be leading to a hypotension. Besides that, they are excreting more glucose in the urine, which will be working as an osmotic diuretic. So all of that will be probably responsible about the weight loss and inducing the hypotension. And also these medications, they have been seen to increase the incidence of fractures. Now, these sodium glucose co-transporter 2 inhibitor should not be used in patients with type 1 diabetes, specifically in diabetic ketoacidosis. In the pancreatic beta cells, they are secreting the insulin, and at the same time they are secreting another hormone, amylin, in a ratio of 100 to 1. So we have, for an example, 100 molecules of insulin, 1 molecules of amylin. Now, the amylin will be released and affecting the alpha cells in the pancreas to decrease the glucagon secretion. Also will be affecting the stomach and slow the gastric emptying. Besides, it will be affecting the brain to decrease the appetite. So all that stuff will be effective in the management decrease food intake and in the management of hyperglycemia. So one agent, pramlintide. Now this agent, it is an analog for the amylin. The amylin, we just wanted to mention it for you. The amylin, it is a 37 amino acid polypeptide. However, the pramlintide, it just only we changing 3 amino acid, number 25, 28, and 29. They replace it with proline. These amino acid, they replace it with proline. And that's they are producing pramlintide. Now, this agent, this drug, supposed to be given by injection, subcutaneous, immediately before eating. And it cannot be mixed with insulin. Now, this agent, it will be metabolized and excreted by the kidney. The side effects you are able to predict, since it is producing a decrease in glucagon secretion and slow the gastric emptying and decrease appetite, specifically because it's decreasing the glucagon secretion. So it may be produce hypoglycemic effect. And also, since it is slow the gastric emptying, might be produce some kind of nausea, vomiting, and anorexia. And finally, I'm going to mention 2 medications that had been used in the management of type 2 diabetes. The colicivilam, this medication, it is a bile acid binding resin. It will be produce its effect by affecting the insulin sensitivity and secretion, and also through the incretin effects, and by changing also in the bile acid composition. This medication will be given orally. It might be leading to a constipation and producing some intestinal gases and so on. The other one is bromocriptine. Bromocriptine, as you already know, that it is a D2 receptor agonist, will produce its effect by inhibiting an excessive sympathetic tone in the central nervous system, and that will be leading to a reduction in the post-meal plasma glucose levels, because it's going to enhance the suppression of hepatic glucose production. The bromocriptine given orally, and it may lead to nausea, vomiting, and headache.